Hi, I wanted to welcome everyone for attending today's educational webinar sponsored by Honoring Choices Idaho, and it is on capacity in advanced care planning conversations. My name is Margie Zamzo, and I'm one of the organizational faculty for Honoring Choices Idaho, and together with Lindsay Winters-Jules, we have put this webinar together to cover some of the questions that have come up over the last couple months about capacity in ACP conversations. The content is being recorded in a webinar, and the way to find this is under the Professionals tab on the Honoring Choices Idaho website. It can be viewed at any time, and there will be additional educational webinars available. And if you have any ideas for webinars and future topics, please contact Lindsay at her email attached. Today's objectives are first to identify differences between competency and capacity. Second, to learn skills to help facilitators assess capacity. To be aware of facilitators' role when capacity is in question and red flags to look for in conversations. And lastly, to become acquainted with Honoring Choices Idaho's new education guides for dementia and advanced care planning. If we talk a little bit about the statistics, 1 in 3 seniors will die with Alzheimer's or other types of dementia. 5.7 million Americans are now living with Alzheimer's. By 2050, this number is projected to nearly triple to 14 million. Alzheimer's disease is the 6th leading cause of death of people aged 65 and older. And most of us know someone who is struggling with this disease. Whether the probability of developing Alzheimer's or the possibility of suffering dementia or pre-dementia, it remains imperative to move the conversation about healthcare decisions upstream to an earlier age, before age 65. It's important to make healthcare decisions and select an agent before not being able to do so. And not just speaking of dementia, but capacity. So people maybe with a stroke, mental illness, or delirium may or may not have capacity. Anyone that you meet with, you need to consider that that individual is capable of making their decisions and be aware of red flags to look for. So let's talk a little bit about capacity. Capacity is the ability to achieve a rudimentary understanding of the purpose, nature, and possible risks and benefits of a decision after conscientious efforts at explanation. So unless you know that a person has been legally deemed incompetent to make their own decisions and has a legal guardian, we assume that each person is capable to make their own decisions. So how do we assess? Unless you know the person has been legally deemed incompetent, all adults are assumed capable and have the right to make any and all of their healthcare decisions. Only capable adults have the ability to complete a legally valid advance directive or any legal document. If a person is deemed incapacitated, the healthcare agent becomes the decision maker. If the person has not designated a healthcare agent, Idaho statute may determine who may be the decision maker. So if a person lacks capacity, who can give their informed consent? And this is per the Idaho statute. Of course, first is the court-appointed guardian of the person. Next would be if the person had named a healthcare agent in a living will and durable power of attorney. Third would be if the person was married, the spouse of the person. Next in line would be the adult child of the person. And then the parent of the person if they were still alive. And then next, the person with formally delegated parental authority to the person. And then any relative of the person who represents him or herself as appropriate and responsible in the circumstances. And then any other competent person who represents him or herself to be responsible for the health care of that person And then lastly, it would be possibly the healthcare provider. We talk a lot about capacity versus competency, but competency is a legal term versus the clinical term of capacity. Competence and incompetence are legal designations determined by courts and judges. A judicial declaration of incompetence may be global or it may be limited. So maybe their incompetence to make financial matters or personal care decisions or medical decisions. Maybe not all three. Decision-making capacity is determined by clinical assessment by appropriate professionals, either a physician, psychiatrist, or a licensed psychologist. Just because someone has a diagnosis of dementia for whatever reason does not mean that they cannot make their own medical decisions. There are parameters to understand. So all adults are presumed competent legally unless determined incompetent judicially, but an adult who possesses legal competence may lack the capacity to make specific treatment decisions. Medical decision-making capacity should be determined by a professional evaluation rather than the courts. Thought disorders, delirium, dementia, extreme phobias, anxiety, euphoria, depression, and anger can affect the ability for decision-making capacity. Oftentimes these are temporary, though. A decision-making capacity should be assessed for specific decisions and cannot be inferred to be present or absent on the basis of the patient's diagnosis. A diagnosis alone is not proof of inadequate decision-making capacity. So remember, a diagnosis alone is not proof that the person cannot make decisions. As facilitators, we need to reflect on our own biases, to be conscious of it, and to work to remain neutral. Poor judgment is an evaluation of choice. It's a lack of decision-making capacity in one area, like money management, but it doesn't mean that the patient lacks decision-making capacity for other decisions. In a clinical setting, if an individual decides to reject treatment options recommended, we may consider that to be poor judgment. But for that individual, in that context, with their beliefs, that decision may be good judgment. So remember, for a person to have capacity, they need to be able to first recognize that there's a decision to be made and understand the needed information, understand the treatment options, understand the likely consequences of each option, so the risks and the burdens and the benefits, and understand the information enough to come up with decisions that are consistent with his or her values. Capacity might be decision-specific, so they might be able to decide on some things but not on other things. A person might be able to comment about quality of life. They can respond maybe to the presence or absence of pain, describe their goals and values. They might be able to name who they want as their healthcare agent. They might be able to make decisions about medical treatment and make decisions about future use of life-sustaining medical equipment. But they may show signs that would be considered red flags that we would need to investigate a little bit further. Capacity might change depending on the time of day. Often those with dementia and Alzheimer's are more alert and verbal in the mornings or after an afternoon nap. Maybe their days, maybe they may not know what day it is, but they know who the people are around them. Surroundings are important. People with Alzheimer's and dementia are often impacted by loud noises, TV screens, people in the room who they might fear. So especially if these conversations are taking place in public areas or facilities where there's a lot of kind of strange people around who the person doesn't feel comfortable with, it might impact their ability to answer questions. The standards for capacity, the individual should be able to understand elements of the decision at hand, understand that there is a decision to be made and that they have the ability to make that decision. They should be able to communicate the choice, whether it be verbal or nonverbal. Thumbs up is sufficient if they show an understanding. They should be able to communicate a rationale for a decision that is consistent with their goals and values. When we're looking for capacity, we use the skills that we've learned in our basic facilitator training. Use teach-back, assess if the individual understands that they are making a decision and they can offer some rationale for the decisions they are making. Rephrase the decision or the question, and do you get the same response? Determine, are the decisions consistent? Are the decisions consistent with the goals and values that they've already discussed with you? The facilitators have a role in helping to identify the red flags that people may show that may put their ability to make decisions in question. And this role may differ if you're a community-based facilitator or you work in a healthcare setting as a facilitator. We'll talk more about some red flags later, but first be aware that this is all facilitators' roles in the discussion. First, communicate with the person's provider and or family if you do see any red flags. Facilitators in healthcare settings should bring concerns to the primary care physician for guidance before completing an advance directive. And document observations if you've got a way to do that, to share with the provider. Even if you are in the community, you might want to make notes for the person or the family to return to the provider with. Include patient-specific statements, actions, family concerns, and maybe some need for supporting documentation that the physician might be able to provide that would say, yes, they've assessed the patient and have determined the patient does have capacity or they have also concerns. Request documentation that supports that decision-making capacity. And we should never accept documents that are signed by a person until a capacity question is resolved. So a quick recap. The role of the facilitator is to first assume capacity and also be aware of your own value biases. Listen to the patient's story for related values that are consistent or inconsistent with their decisions and or behavior. Recognize when decision-making capacity is in question. Ask yourself, does the person understand what is being asked? Do they understand the consequences of this decision? I think it's important to remember, too, that some families have dysfunctional behaviors, and it's not the role of the facilitator to assist with family dynamics. But pay attention to your own biases. Refer to that primary care provider if you come across red flags, and understand that some family behaviors may be very different from what you have experienced or would do. But that just might be the way they function. And then we return back to our basic facilitator skills that can help you assess for capacity. Teach back for understanding. Does the patient adequately understand the information being presented? The patient maybe doesn't agree with your interpretation, but they should be able to repeat what you said. It's a good time to remember your teach-back skills. Understand the choice to select an agent and the role of the agent. Do they understand that the healthcare agent will guide future healthcare decisions, and that they understand the decisions will be honored when the patient cannot speak for themselves? And understand, too, that their choices can be changed at any time. Explore the meaning of words and phrases. Clarify meanings of words. Is the logic the person uses to arrive at this decision not rational or irrational? Look for themes of consistency. Ask the question a couple of times to see if you get a similar response. Is the decision consistent with the patient's values? Is there a change that the patient can explain? And watch for nonverbal communication. Do they have a blank look, the deer in the headlights look? Are they constantly looking at their agent or their family for responses? And again, remain value neutral. Facilitator skills continue to check for verbal understanding of the severe neurological injury scenario. So what they would want in the event that a severe injury or illness occurs. Observe behavioral cues that suggest the lack of capacity. Are they fidgeting? Do they get up and walk around? Seek insight from others who maybe know this person. If you have questions about the patient understanding, openly share your reasons for your specific questions with the patient and the person's presence, whether it be agent, family, or other friends. It's important to share that information, to say, I'm concerned that you do not seem to understand this, or again, using your teach that skill. So let's look at some of those red flags. Usually they're behavioral clues. There's slow comprehension. They have that blank look. They repeat the same question multiple times. They're inattentive to the conversation. They're looking at others for cues on how to respond. The agent or the family member is answering questions or prompting the responses. If the red flags don't give you enough information to refer, assume capacity and notify the primary care physician of your concerns. Here's just a brief view of the new educational tools that are available on the Honoring Choices website under Educational Tools on dementia and advice for being a healthcare agent for a person living with dementia. These provide great information and guidance for people who have questions or concerns about decision making. Let's go to a couple of scenarios that you can think about. Let's say a person does not stay on topic and seems distracted. The healthcare agent gently encourages the person to answer the question, but the person just wants to be left alone. Is this cause for concern? Yes, distraction and ability to stay focused is a common behavior of someone with memory loss. What's the next step? Document your observations and refer to the primary care provider for further evaluation of capacity before moving on. Let's look at another person who's recently suffered a stroke and was discharged from the hospital. When asked questions, the person answers questions slowly with a delay in response, and their speech is slurred. She is communicative non-verbally. Is this cause for concern? Think about what interview skills you might use to ensure that the person is capable of completing the conversation and/or the paperwork. This person is probably fine to fill out their advance directive. They're answering questions and following the conversation, although slow in response and their speech is slurred. There are ways to communicate other than verbally which are valid and can provide useful information. This person may have suffered some post-stroke injury that is impairing their speech or their vision, but the person is capable of participating in a conversation about advanced care planning. Let's say you're meeting with a person and the appointed healthcare agent. They are casually joking about pulling the plug if I'm a vegetable. You then present the scenario about the unexpected injury or illness that leaves you unable to make decisions for yourself. The person has a confused look and doesn't seem to understand what you are asking. Is this cause for concern? What are your thoughts? And what skills might you use to determine their understanding? Ask the person to restate the scenario, describing what is being asked. It might be cause for concern. Ask them, can you tell me what I just said? Use your teach-back skills. Maybe they're hard of hearing. Have they heard you correctly? Watch for cues that the person is looking to their healthcare agent for answers to. And is the response congruent to the goals and values previously discussed? Here's some questions to consider. Have capacity issues arisen in any of your conversations in the past? What concerns do you look out for during conversations that might be a red flag? And what concerns might bubble up during conversations? Again, that leads you to question whether or not you should refer this person back to their provider for a more in-depth assessment of their capacity to make decisions. So this kind of covers just a brief overview of capacity to make medical decisions and how to help evaluate patients during this time. If you have any questions or ideas, please give us an email, shoot us an email, and we'll try to answer any questions that come up. And if you have any other topics that you'd like to have covered in a webinar, please let Lindsay or myself know. Thank you very much for attending this webinar, and we'll see you soon.